Hello, my name's Emma Burkitt Wright. I'm a clinical research training fellow in genetics in the Manchester Biomedical Research Centre, and I'm also a specialist trainee in clinical genetics. And today what we're going to do is run through a few questions which we've selected to be representative of the kind of topics that come up for MRCP Part 1. So, on to our first question. We have a young girl who's pregnant. Her father is affected with haemophilia. We know haemophilia is X-linked and that she's carrying a baby boy. So we need to know what's the chance of her son being affected with this condition. Give you a moment to think about things. The options being 1 in 2, 1 in 4, 1 in 6, 1 in 8 or 1 in 16. If you've made up your mind, so the answer is 1 in 2, and why is this? We can draw the pedigree. We know that her father is affected, therefore she is a carrier. She has a 100% chance of being a carrier, and there are therefore 4 possibilities for each of her babies. There's a 50-50 chance that it will be a baby girl, and within that, an equal chance as to whether it's a carrier or an unaffected female. There's a 50-50 chance that the baby will be a boy. We already know that the baby she's carrying at the moment is a boy, and therefore it's possible that the boy will inherit her altered X chromosome or her normal X chromosome. And therefore there's a 50-50 chance that he's affected with haemophilia or unaffected with haemophilia, and that's why the chance is 1 in 2. So we'll now move on to question 2. And this is a 30-year-old man who's found to have 3 adenomatous polyps in his colon at colonoscopy, which is unusual at that age. And then he mentions that his father died at 45 with colon cancer, paternal aunt had a rectal cancer at a similar age, and his paternal grandfather also had colon cancer at 50. And so the most likely diagnosis here, we have 5 options: familial adenomatous polyposis, Cowden syndrome, Gardner syndrome, hereditary non-polyposis colon cancer, or Peutz-Jeghers syndrome. And the answer is D, hereditary non-polyposis colon cancer. So why is it not familial adenomatous polyposis? Well, in FAP, people tend to have 100 to 1,000 or more polyps, so clearly that's not the situation here. Cowden syndrome is associated with polyps, but also not just bowel polyps, so thyroid cancer is something that's associated, and it's a very unusual condition. Gardner syndrome is allelic to FAP, and again that's a very rare condition, so it's not likely to come into the most likely diagnosis category unless the presentation is classical, which it isn't here. And similarly, Peutz-Jeghers syndrome again can be associated with polyps, but it's often small bowel polyps, and that's not what we're talking about here. The answer here is HNPCC, because this family actually meet the Amsterdam criteria for the diagnosis of this condition. The Amsterdam criteria we've got here, you need 3 relatives with histologically confirmed colorectal cancer, one of whom is a first-degree relative of the other 2. At least 2 generations should be affected, and one of the cancers should occur before age 50. And there are actually modified criteria now reflecting the high risk of endometrial cancer in women with this condition, and also other tumours that we know to be associated, like tumours of the renal pelvis or ureter, small intestine, and cholangiocarcinoma. It's also important to say with any of these things that we should be ensuring that the histology is being checked up, that we're not relying on word of mouth. On to question 3. We have a healthy 20-year-old man sitting in front of us. He plays professional rugby and he's never been ill in his life, but his brother died at 7 with cystic fibrosis, and understandably he's worried about his chances of being a carrier. So what do we think these might be? We've got several options there. So why is it 2 in 3 chance that this man's a carrier? Well, this is because we know that he's absolutely fit and healthy in A1 physical condition, and that is telling us in the context of the exam that there's no way he's affected with cystic fibrosis. So this fourth option that you can see on the right with the 2 altered gene copies is something that doesn't apply to him, and that's why it's crossed out. So we're left with 3 options: that he's inherited both his parents' normal alleles, or that he's inherited normal one from dad and the altered one from mum, or vice versa. Therefore, he has a 2 in 3 chance of being a carrier for this condition. Another 20-year-old man come to see us. He's been found to have hypogonadism and infertility. Puberty was normal, but he's tall with gynecomastia and small testes, but a normal sense of smell. And we're asked which condition would be high on our list of differential diagnoses. The answer here is Klinefelter syndrome. Well, why is that? Firstly, Klinefelter syndrome affects 1 in 500 men. So if we have a presentation that's consistent with that, then that's going to be high on our list of differential diagnoses, given the rarity of many of the other conditions we're talking about. XYY syndrome is not associated with hypogonadism or infertility or gynecomastia. Men are often tall when they've got this condition, but that's really the only thing that would lead you to think about this. Marfan syndrome, very much the same story, that people are tall, but they don't have the fertility and endocrine issues that we've got described here. Kalman syndrome is a more unusual condition than Klinefelter syndrome, but it does present with hypogonadism and infertility, and therefore that's something that is worth considering. But one of the hallmarks of Kalman syndrome is anosmia or hyposmia. So if this man has a normal sense of smell, essentially the question is telling us he does not have Kalman syndrome. Fragile X syndrome has been thrown in as something of a random really for this question, and people with Fragile X syndrome often actually have large testes rather than small testes. And that shouldn't really be high in anybody's differential, not least because significant learning difficulties are part of that condition, and that's nothing that we're talking about here. So on to question 5. 19-year-old woman who's severely hypertensive, but she's got cafe au lait patches and some axillary freckling. She had surgery for scoliosis as a child, so there's likely to be some underlying diagnosis. I'll give you a moment to think about those options. This woman's got cafe au lait patches and axillary freckling. If she's got more than 5 cafe au lait patches, then that in itself is consistent with the freckling with a diagnosis of NF type 1. Surgery for scoliosis as a child, we know that scoliosis is something that happens quite commonly in NF1 as well, so that's all pointing towards this as the diagnosis. Marfan syndrome wouldn't be associated with the skin changes that we've got described here, though it is associated with scoliosis. Hypertrophic cardiomyopathy could cause hypertension, but it would be relatively unusual to have that as the presenting feature, and it doesn't tie in with the other things that we're talking about. Tuberous sclerosis can cause a variety of skin problems, but we're not actually thinking particularly about cafe au lait patches and axillary freckling in that condition. It's more to do with the badly named adenoma sebaceum on the face, shagreen patches and hypopigmented macules. And Cushing's disease, again, whilst that might be relevant in the context of hypertension, it's more usually a generalised skin pigmentation difference that people have, and there wouldn't be any obvious association with scoliosis. In terms of why this woman might have severe hypertension at 19 years of age, we know that both renal artery stenosis and pheochromocytoma are associated with neurofibromatosis type 1, so those are both really important things to be thinking about in this clinical presentation. And here we've got the diagnostic criteria for NF type 1, 6 or more cafe au lait macules, which need to be over 5 millimetres before puberty or over 15 millimetres after puberty, 2 or more neurofibromas, or 1 if it's a plexiform neurofibroma, freckling as we've already discussed, optic glioma, Lisch nodules, which are iris hamartomas, or some unusual bone thing such as pseudarthrosis of the tibia is the most classical of those. So we'll move on to question 6, and a 40-year-old man who's breathless and bradycardic with ptosis. And there's a family history of a muscle problem in his sister, and his sister had a child who died as a baby. So what diagnosis are we thinking about? I'll give you a moment to think about your answer. Myotonic dystrophy affects 1 in 5,000 people, and it's a trinucleotide repeat disorder, so it shows anticipation. We've got anticipation here because the sister had the condition herself but had a severely affected child. Why is it not the other options? Ptosis is something that we see in myotonic dystrophy, and it's not a particular key feature of any of the other conditions we're talking about here. Duchenne muscular dystrophy and Becker muscular dystrophy are both excellent conditions. We've already discussed about Duchenne. And facioscapulohumeral muscular dystrophy, again, an autosomal dominant condition, so that would be consistent with the inheritance pattern that we're talking about here, but it doesn't tend to present in infancy. There's no anticipation generally in this condition, and therefore we don't think that that would be the appropriate answer. Spinal muscular atrophy, an autosomal recessive condition generally, and again that's very much not in keeping with the presentation that we've got here. Got here myotonic dystrophy key features: myopathic face with ptosis, myotonia, particularly noticeable when you shake hands with somebody and they can't release their grip, cataracts, which might be the only presenting feature in somebody who's extremely mildly affected, diabetes, testicular atrophy, and cardiac conduction defects. Move on to question 7. When is a gene mutation causing a particular genetic disorder said to be highly penetrant? So this is a simple question of definition. High penetrance means that if you have the gene version that's associated with the disorder, you will get that disorder. So individuals with the mutation invariably develop the phenotype. We can think about highly penetrant disorders like Huntington's disease. If you have the full expansion of the Huntington's gene, you will get the condition, though it's not necessarily possible to predict what age that will happen. So the other options are clearly not correct in this question. Affecting a large number of the population would be to do with prevalence. Affected individuals with the same mutation having a very similar phenotype would suggest that there was similar expression, and we know that that's nothing to do with whether somebody develops the condition or not. Manifestations early in life, again, that's to do with age of onset rather than penetrance, as we've already discussed with Huntington's disease. Affecting both sexes equally, again, that's not a reflection of high penetrance or otherwise. So move on to question 8. We have here a middle-aged woman who's got increasing breathlessness on exertion and a son with Duchenne muscular dystrophy, and her brother had it as well. So what would our concerns be about her? So the answer is cardiomyopathy, and that's because female carriers of Duchenne muscular dystrophy run a 10 to 20% lifetime risk of dilated cardiomyopathy. And this is something that actually infrequent screening is recommended for every 5 years for women who have no symptoms at all. Clearly, in this context, a woman who's got symptoms, you're going to have a very low threshold for investigating that. The other conditions that we've got in the list are none of them specifically associated with being a carrier for Duchenne muscular dystrophy. We know that this woman's a carrier because her brother and her son are affected. We've actually got here a pedigree of somebody whose father and son are affected, and clearly that's very unusual in Duchenne muscular dystrophy because boys with this condition wouldn't normally have children. Move on to question 9. We have a 70-year-old man from Northern Europe with hemochromatosis, and his son has also got the condition. And they've both got the same genotype for this condition. They're homozygous for the common mutation. So how can we explain this? This is a classical description of pseudo-dominant inheritance. What is pseudo-dominant inheritance? Essentially, it's when an autosomal recessive condition appears in successive generations because both, in this case, father and son, have got 2 disease alleles. And this happens when disease alleles are very common in the population. So if we think about hemochromatosis and the C282Y gene mutation, which we know is present in 1 in 6 or 1 in 7 of the Northern European population, we have the gentleman at the top who's got the 2 altered gene copies and hence hemochromatosis. Clearly his wife has got at least 1 altered gene copy, and that's what she's passed down to their son, in the context of their son also getting an altered copy from his father because both of his father's copies are altered. And we also see pseudo-dominant inheritance in another situation in rarer disorders where we've got consanguineous families. Sometimes recessive conditions can pop up in several generations. So we'll move on to our final question, and it's another question of definition really. Genomic imprinting is seen in which of the following conditions? So the answer, I hope, is jumping out at you here, that it's Prader-Willi syndrome that we're thinking about as the only imprinted condition in this list. Neurofibromatosis, Huntington's disease and Marfan syndrome are all autosomal dominant conditions, whereas Hurler syndrome is an autosomal recessive disorder. And Prader-Willi is the only one which is an imprinted condition. And we can see here pictured Prader-Willi syndrome results when you have a paternally inherited deletion of a region of chromosome 15q. And the features of Prader-Willi syndrome are of extreme neonatal hypotonia and resultantly poor feeding. Having fed very poorly as babies, people become hyperphagic in childhood, so they're kind of kids who'll be raiding the fridge in the night, and they also have learning difficulties. The converse disorder that you hear of in context with Prader-Willi syndrome is Angelman syndrome, and that's when it's a maternal deletion of the same region, and this causes a condition that children have characteristic movements and often severe epilepsy. So I hope that that's been helpful to you in planning your revision for MRCP Part 1 genetics topics. Thank you very much for your attention.